I look forward to your talk, BJ.
Thank you. Mhm.
Great. Oh, look at that. Everybody's coming in. Hi, everybody. We'll just wait a few more minutes for people to come in.
You can see my full screen, right? Not the Zoom.
Yep.
Okay.
Yeah, no, it's just slides.
Okay.
It's good to see some names from MGH here as well. It's great. Okay, Tracy, it's 12:02. Should we start?
Sounds great. Let's
Okay,
get to it.
great. Well, yeah, I'm sure people will come trickle in. So, welcome everyone. Not everybody knows me. I'm Andrew Stern. I'm a cognitive behavioral neurologist at Brigham and Women's, and I'm very happy to introduce Vijay Kolachalama from BU to give us a very interesting talk. And I was telling Tracy that Vijay and I met playing squash together. And by chance, after the game, it so happened that we asked what each other did, and we both happened to be Alzheimer's researchers. And from there, I've struck up a lot of conversations about diagnosing Alzheimer's disease and related dementias. And it turns out that Vijay is trained and is a bona fide card-carrying computer scientist and came to dementia research after a long journey through artificial intelligence and machine learning, and is the real deal. And he's wonderfully decided to use his powers for good and has some very interesting data on the use of AI and machine learning for everything from diagnosing Alzheimer's disease to digital pathology of cancer as well. He's over at BU in that really cool looking building with the stack of looks like a stack of books with a beautiful view of Back Bay, and holds numerous grants from NIH and the Gates Foundation and various other sources. And so we're really excited to have him. And take it away, Vijay.
Yes. Thank you, Andrew, for the nice intro, and thank you for inviting me to give this talk. I guess today, my goal is to sort of really talk about some of the work that we've been doing recently in the context of building some interesting AI-based methods for looking at multimodal data collected using in a routine neurology setting for broadly dementia assessment. Uh, um, I think our lab's goal has been mainly to really think about building assistive tools for neurology, and I think we've been kind of slowly making some progress to look at dementia. I've been asked to basically share two of these slides, so I'll probably pause here. I mean, I don't know if I have to pause for like a few
This is
seconds
great.
here. This
That's
is one,
sufficient. Thank you.
and there is one more slide, I think, this one. So I'll move forward. This is actually an important slide for me before I go into the topic. I just want to talk about who we are. Just as a quick introduction, our lab is a mixture of PhD students in computer science as well as MD students from the medical school at BU. We collaborate very closely with some practicing neurologists, neuroradiologists, neuropsychologists, and neuropathologists. Some of the names might sound quite familiar. We learn clinically relevant aspects. Obviously, Andrew also taught us a lot of things more recently when we talk with the clinicians. So it's great that we are kind of interacting together because the kind of questions that we are attempting to address, it requires basically a multidisciplinary team. So in this talk, I'm not going to spend too much time to discuss why I'm doing this because I think rather focus on how we are trying to really solve some of the clinical questions. Using some methodologies we are trying to develop, mainly related to machine learning, and applying them to multimodal data, such as neuroimaging and other routinely collected clinical information. Um, so Back in 2018, I saw this paper, which I think kind of somewhat inspired me to really think about it. And I think they made some statements. I think this is a sobering reality here, which is there is a shortfall of experts around the world. I mean, obviously in Boston, we're very lucky to have all the experts, but overall, if I go to India, where I'm from, it's really bad. The time it takes for an appointment is very long. And I think for that reason, I think I'm really motivated to build some assistive tools using routinely collected clinical data that can serve as, hopefully someday be in practice for broadly thinking about Alzheimer's disease and related dementias. And as we learn from the clinicians, I've tried to understand that in order to build these sophisticated systems, we got to be able to leverage all this multimodal data in native formats. And when I say multimodal data, I'm talking about clinical demographic data, anything that comes from EHR, such as patient history, bedside cognitive tests, neuropsychological tests, neuroimaging, EEG, etc. And as we build these models, one of the painstaking things that we do over time, in fact, I would say 80% of our time we spend on really validating our frameworks. And we approach that using all these different ways. One is obviously thinking about computational validation. We are also trying to see if we can understand how these models have some corresponding biomarker evidence. We also bring clinical experts to do some expert level comparison. And then finally, if on some cases, if we have some postmortem data, we also think about postmortem validation as well. There is another interesting statistic that I found, which I also thought was very interesting. Some of you may be involved with dementia trials. So clearly, it's a very expensive endeavor. And this was a paper, it's a white paper, I think was published by the group at USC, where they kind of really listed all these different barriers for clinical trials for Alzheimer's disease, but I think broadly applies to dementia. So clearly the screen failure rate is extremely high, at least as mentioned in that document. So partly because I think the clinical diagnostic criteria may not necessarily meet the clinical trial enrollment criteria. So clearly there are these PET scans and other things that are expected to do, and you normally don't do them in a routine workup. So there is a uh, so there is a need, I think, also to really think about how to build these sophisticated approaches to think about clinical trials as well. So with those two sort of really motivating questions, I think our research questions have been kind of really to think about how to build effective machine learning models, broadly deep learning models that are interpretable so that we can explain what's going on with these models, and how to leverage these deep learning approaches to process routinely collected data, multimodal data to assess all kinds of dementias. And finally, like I said earlier, we need to really think about how to validate these things, because unless we validate them, it's hard to really think about translation. So I want to quickly talk a little bit about the data set that we have access to over the past, I would say maybe 7 years, 8 years or so. We've been slowly collecting data across multiple different cohorts. Some of them obviously are publicly available, like ADNI and UK Biobank and other things. So we've been kind of really collecting all the data from them. And I think the one in the center that you see here is coming from the Framingham Heart Study. BU is the headquarters for the Framingham Heart Study. So we have access to the FHS data. I'm on the executive committee there. So there's a lot of interesting data that they are collecting as well. And we also have some collaborations with folks at Stanford. So also it's a Pacific Woodall Center. So they also have provided some data on mainly Lewy body dementias. So one of the things as we collect this data is we really think about how to harmonize all this data, because we are talking about multimodal data, not just MRI scans, but we have to come up with automated pipelines that can allow us to harmonize the data across all these different participants coming in from all these different cohorts. So there is clearly a lot of work to do even before we think of machine learning. And I think I'm kind of really outlining here an overview of what it means to spend time to build all these pipelines. So clearly we talk about data collection, data processing, normalization, harmonization. And then in the context of imaging data, we are talking about registration, normalization, and other alignment techniques to sort of really think about how to put all these data together to make the data amenable for machine learning. I think that's kind of really the significant amount of time that we spend. And then maybe I would say 25% of the time we actually really think about model development. Um, so with that, I just want to give a brief overview on exactly what I mean by machine learning. So I want to start off by by talking about a generic concept in modeling a task. Um, so let's say we consider a problem of deciding whether a person has cognitive impairment, when given a large number of numeric input variables that kind of represent the characteristics of that person. One standard approach is to use, let's say, logistic regression that estimates how to weight each of those input variables so that the weighted sum is a good indicator of cognitive impairment. But as you all know more than I do, dementia is very complex to diagnose. There are many kinds of things going on and often involves complex interactions. So if we want to really model this correctly, then we can add extra inputs known as these interaction terms. Each represents basically a product of two or more input variables. But if multi-way interactions are kind of need to be modeled, the number of interaction terms basically increase exponentially. So the neural network alternative is to add a layer of hidden factors or hidden layers. Basically the first step here is to sort of determine which hidden factors are active, and then the active ones are used to determine when the disease is present or absent. So in the context of images as inputs, there are certain deep learning approaches such as convolutional neural networks that basically exploit the structure of the image, which is organized in this simple XYZ format or a grid format. So in addition, the hierarchies or the intermediate layers that I talked about before of the neural network, they are created by performing these certain operations called convolutions. So the convolutional operator is basically a generic filter that can be applied on these images, and it's a deep learning architecture that can be used or developed when images are often the inputs. So for example, if I want to learn from a brain MRI, a scan of hundreds of individuals to predict, who have signs of brain atrophy, for instance, corresponding to, let's say, Alzheimer's, then my go-to deep learning neural network would be this convolutional neural network. And just to clarify, the convolutional neural network is just one among many, many deep learning approaches that allow us to process this intrinsic structure of complex data, such as image. So in the recent years, there has been tremendous progress on this field, and there are many, many modern machine learning approaches that I think are in play. So again, in order to again build some image processing pipeline, clearly, like you can see here, one of the key steps is to think about volumetric registration. I'm talking about 100,000 participants, which means I have very, very large number of volumetric scans. So I can't simply rely on something like a FreeSurfer or some other tool that's out there, because we are trying to make sure that the data is actually amenable for some of these sophisticated methods. So we have internally built these pipelines to really think about registration. So here in this case, you're seeing the source image and a target image. So we are trying to really align the images in all these three planes, sagittal, coronal, and axial planes for each case. And then we have to do that across all these 100,000 cases. So I would say it's not 100% automated, but I think we are trying to get there to make sure that we are doing this in a most automated fashion possible. And then once the registration part is done, we also have to think about removing certain things that we probably think are are going to interfere with the model development, or maybe not relevant in the context of looking at what's actually inside the brain. So we have this again, a neural network approach which automatically takes each slice in all the three planes and then tries to remove the skull, so that the output of that is actually an image, which is something that can be useful for the next step. One of our main motivations was to see if we could basically build and develop and actually validate an interpretable uh, deep learning framework that could use readily available data such as demographics and bedside cognitive testing and imaging such as MRI to predict if a person is at risk of Alzheimer's. So it all started when a PhD student named Shangran, who is now at Microsoft, uh, is the first author of this paper that was published in Brain, came up with an idea of creating a very computationally efficient deep neural network to process the entire raw MRI scans of the brain on hundreds and on thousands of those cases. So this is a sort of a variant of the convolutional neural network that I talked before. It's basically a framework where we take these volumetric patches automatically, and then the it outputs basically these volumetric heat maps that can nicely highlight subregions within the brain that point to a high degree of association of disease risk, which was then used to make the final prediction. With this kind of framework, one can visualize these high-risk subregions, and this was actually an innovation that was appreciated by the reviewers uh, from the computational standpoint. This framework can very efficiently work because it can process these volumetric scans quickly. As the model was trained to sort of infer these local patterns of the cerebral structure that suggested an overall disease state. Um, and after we built the models, one of the things we did was we basically trained the model on one cohort, such as the ADNI cohort. And then we sort of used the other cohorts, such as the Framingham Heart Study and the National Alzheimer's Coordinating Center data coming in from 37 ADCs, and also the Australian cohort to sort of really validate how the model performs on those external cohorts. And I think this was kind of really an important task that we keep in mind to do computation validation. Uh, and that's how, at least I think, we are trying to sort of really think about creating these robust pipelines that are not just one fancy method and one data set, but hopefully generalizable enough across many different cohorts. So as an extension, what we did was to now, in addition to thinking about MRI scans alone or just demographics, we then collected a lot of data coming in from other neurology workup data. For example, neuropsych testing, medical history, functional assessments. So all this data was then combined with the MRIs to ask a slightly more sophisticated question. And in this case, what we asked was to really think about, okay, given a person's information, let's say demographics, patient history, functional assessments, neuropsych assessments, and MRI scans, can you, the first pass, at least assess if the person has normal cognition or healthy cognition or some sort of mild cognitive impairment or dementia? And if the model tries to predict if the person has likelihood of dementia, then is this dementia due to Alzheimer's or some other etiology? So in this case, again, we did a lot of work on getting data from multiple different cohorts. As you can see here, there are some numbers where we were able to get at least a decent number of cases for even non-Alzheimer's cases, non-Alzheimer's dementia cases. And this multimodal neural network sort of was able to process both the imaging data as well as the non-imaging data, the neurology workup data, and then combine that information to make this kind of a two-tier assessment. One of the advantages of some of the things that, because we've been building internally, is to sort of really think about, okay, now the model is built. So what is the model actually looking at, and how is the model trying to assess a person's, let's say, status on whether they have healthy cognition, MC, or dementia? And again, after that is done, then is that dementia due to Alzheimer's or non-Alzheimer's? And you're seeing here is this rank ordered list of features or input information of person level information that turned out to be important in terms of making that specific assessment. So this is another way to sort of really bring that kind of explainability to the model and see how the model is actually trying to assess these different questions. And then in about 100 cases or so, we had basically neuropathology data. So what we did was we took the model predicted probabilities or model predicted assessments, and then we saw how they sort of aligned with neuropathology grades on some of these cases. And the data was obtained from the NAC, which is the National Alzheimer's Coordinating Center, the ADNI, about 25 cases, and some from even the Framingham Heart Study. And what you're seeing here is just basically, using the one-way ANOVA test, we rejected basically the null hypothesis of there being no significant differences in the model predicted scores between the semi-quantitative neuropathology scores as well. So here we have the ABC scores listed here, and the model seems to at least do a decent job in terms of predicting the severity of the disease, if you will. And then again, just to add that interpretability to the model, what we did was we took those heat maps, like I said, those interpretability maps that are coming from the model, and we tried to spatially align the prediction heat maps on the MRIs itself. And then we were asking the simple question as to see how the model sort of really even predicts those regions of interest that correspond to the disease. So this is basically a case from the Framingham Heart Study where the neuropathology report was available. So what we did was we just basically took that and then aligned it. So this subject actually had clinically confirmed Alzheimer's disease with affected regions. I think are bilateral asymmetrical temporal lobes. I always make a mistake on identifying that. And the right side hippocampus is also affected. The cingulate cortex is also affected in this case, the corpus callosum, and part of even the parietal lobe and the frontal lobe. So the first column basically shows just the MRI, and then the second column basically is the model predicted heat map on that MRI. And the third column is simply the alignment of the model predictions on the MRI. And the fourth and the fifth columns are talking about the neuropathology grades that were basically graded in each of those specific regions. And then after doing these kinds of assessments, I think the second tiered question was about to think about NC, MCI, and dementia. And then if dementia, then is it due to Alzheimer's or due to non-Alzheimer's? And then when I met Andrew and a few other people who kind of gave me a good lecture on, that's not how things are done in a neurology clinic. So I think this is basically a brief summary of what I learned from Andrew. And correct me if I'm wrong, Andrew. So basically, how are neurologists evaluating patients today? Maybe a patient walks into the clinic with a family member with some kind of a chief complaint involving some memory-related issues. The neurologist then becomes a data scientist and then gathers information coming from multiple different aspects such as demographics, personal level history, medications, etc. Perhaps administers some tests involving neurological exams, bedside cognitive exams, and even refer a neuropsych assessment. And sometimes they order even an MRI. So technically, when you have all this data, all this multimodal data, I think the goal here is to sort of really assess the cognitive status, which is, again, the first pass is healthy cognition, MCI, and dementia, but then go much more deeper to understand the underlying cause of dementia. Is it Alzheimer's disease? Is it depression? Is it Lewy body? Or what are the things going on? And oftentimes, at least in the cases that we have seen, there are multiple factors that are simultaneously involved, so which means mixed dementias, right? So that's kind of really, I think, probably a slightly better picture than what I presented before. So with this as the goal, what we did was to again go back into the data sets that we have had and collected a lot more data, and then ask that sophisticated question where can we perform a more effective differential diagnosis of dementia. So again, here is a list of all the things that we have collected across all these subjects. This is over a data set of about 50,000 cases or so. And then again, based on the advice that we received from a group of neurologists, we started to then think about different categories of these etiologies. So on the left side is basically a table. I'll slowly go through the list here. So the first three are obviously that normal cognition, MCI, and dementia. But then you have underneath them 10 distinct groups of etiologies, right? So obviously Alzheimer's disease is one of them. And then we grouped the Lewy body dementias, which is basically dementia with Lewy bodies and PD dementia in one category. There is vascular contributions. There is prion disease, which includes CJD. There is FTD and its variants. And there is NPH, which seemingly is a distinct category. And there are these systemic factors such as infectious diseases, substance abuse, alcohol abuse, medications, etc. And there is a psychiatric component as well, which includes schizophrenia, depression, bipolar, etc. And there is a traumatic brain injury component, which could possibly also cause dementia. And then the 10th category here is this other dementia conditions, which I think was, again, sort of really not a perfect definition, but still it includes some aspects such as neoplasms, Huntington, etc. So with this sort of this very broad goal, so we again trained a more sophisticated neural network that combined all this multimodal data and then started to address all these different things in a systematic way. So which means we are still asking that two-tiered question, which is, is the person having healthy cognition, MCI, or dementia? But after that, now the model is trying to understand what is the root cause of dementia in this specific individual. And in fact, because we have these 10 things listed, we can also identify potentially even mixed dementias as well in this context, right? So here is some performance curves. The model was able to sort of really get almost like a 90% accuracy on assessing these conditions. And then after the computational aspect, we started to ask more questions related to validating the model. So on the top plot here, you see is after the model made that prediction of the probability of this person likely to have Alzheimer's disease, we divided the participants into two groups. One is basically to understand if the model has even the ability to predict uh, uh, Alzheimer's in the context of MCI. So MCI due to Alzheimer's is one category. And again, obviously, if the person has dementia, then the underlying cause could be maybe AD as a contributing factor. So interestingly, our model was able to sort of really assess the differences between those people who have prodromal disease due to Alzheimer's. So that was really an interesting finding. And the bottom here you're seeing is that the model probability sort of really increased as the CDR ratings increased on all these different conditions, on all these different cohorts. So on the left bottom, you see the NAC cohort, center is the ADNI, and the third is the Framingham cohort, where the probability of the model predicting to the person having dementia sort of really increased as the CDR rating increased. And please note, CDR was actually not used as the input to the model, but only to sort of really think about validation here. Um, and then here is a slide that basically summarizes the model's ability to assess both single and sort of this co-occurring or mixed dementias. The bottom part is basically showing the number of cases, but the color table here is basically showing the performance of the model in terms of assessing these dual pathologies like AD and LBD, AD-FTD, and so on and so forth. So that I think was one of the key innovations here is that the neural networks or the technology I think has evolved so in so much that we can now ask these more interesting questions or probably more relevant questions in the context of ADRD broadly. And then after this, what we also did was to really understand how the model predictions align with some kind of a biomarker evidence. So on the top row, you're seeing basically information coming from PET. On the top left is the amyloid PET data. Center on the top is the tau PET, and the top right is the FDG PET. So here we again took the model predictions. Again, because there are those 13 categories, the model actually makes the prediction on each of those categories independently. So I can effectively take the model's prediction on whether the person has, let's say, Alzheimer's disease and take that probability and align that and see if the model is able to effectively differentiate between those who are amyloid positive versus who are not. And similarly for tau and FTG as well. So the top row is actually showing the probability of Alzheimer's disease on the y-axis, and the two cohorts I think are split on the x-axis. So again, statistically, the model was able to identify the differences between those who are PET positive versus those who are not. In the bottom, we sort of expanded beyond Alzheimer's and looked at probability of frontotemporal degeneration with MRIs and FDG PET. And in the context of Lewy body dementia, we looked at some DAT scans, and we were also able to show that the model predictions aligned with the presence of disease in the context of DAT scans for LBD. And then one more thing we did was about 150 cases or so. Again, we looked at the neuropathology data and then ask the same question, which is how is the model able to align with the neuropathology information or neuropathology evidence? The top row here is showing the model predictions of Alzheimer's disease with ABC scores. And then the second row here is showing the model probability of Alzheimer's with cerebral amyloid angiopathy and arteriosclerosis. And then the bottom row is showing the model predictions with the model predictions of vascular dementia, the first two, and FTD on the bottom right. And I think this is kind of giving us the evidence that whatever the model is trying to do by processing all this multimodal information is somehow able to sort of align with some kind of evidence of disease that is observed in neuropathology. And finally, one last validation thing we did was to think about clinical validation. So this was really the icing on the cake, where we invited about 12 neurologists and 7 radiologists practicing, all of them. And then we basically took about 100 cases or so, randomly selected, and we gave them all those cases to review. And they were asked the same question, which was, again, identify if the person has healthy cognition, MCI, or dementia. And if they think the person has dementia, identify all those etiologies that might occur or that might cause dementia. So they did the same exercise. Each one of them did independently on those 100 cases. And the same thing in the context of radiologists, what we did was we gave them basically those cases that were already diagnosed with dementia. So they were not doing the NC, MCI, DE assessment, but they were going in with those cases and identifying which of those 10 etiologies were actually contributing to the condition. And we sort of averaged all that information. And then here, what I'm showing you is a result, which is kind of really a summary, which was really encouraging for us to show that in that randomly selected cases, the 100 cases, the neurologist assessments augmented by the AI model exceeded basically the neurologist only evaluations by about 26.25%. I have a similar result even for the radiologist, which I didn't get a chance to show here, but the assessment was also done independently on the group of radiologists, and we also observed an increase in terms of the assessments. So again, this was published recently in Nature Medicine. I think, again, this is basically a summary of the work that we have done, starting from asking a very simple question where the goal was mainly to think about creating a method, an interpretable machine learning method that can do some sort of a binary classification, although may not be clinically that relevant, but at least it at least got us going in terms of building those very sophisticated neural networks, interpretable neural networks. And then we started to engage more clinicians and understood more about the clinical question. So the second question was more about trying to really differentiate between NCMCI and dementia, but again, also if dementia, then how do you sort of really think about Alzheimer's as a thing causing dementia versus non-Alzheimer's dementia? But I think as we expanded further, we were able to sort of really go in deeper to really look at multiple different etiologies, including mixed dementias. I think that was really the latest work that I think was published. We are right now, I think we have this tool in the form of like a software. So what we are doing right now is we are doing some pilot studies at a few medical centers. One is a medical center in Arizona, Brain and Spine Center. They see about 10,000 patients a year. They have 3 clinics, and they are sort of really integrating this tool in their clinic today because they also do a lot of clinical trials, but they also want to sort of really test it out and see how this is going to potentially help them, because most of the times, at least in their case, the neurologist, I think the number of neurologists are not that many. So they are relying on nurse practitioners and others to sort of make those initial assessments. So they feel like this can potentially help their workflow. We don't have any FDA approval yet. So this is basically a research study just to understand exactly what's going on in that setting. We also recently started a collaboration at Carle Health, which is connected with the University of Illinois, Urbana-Champaign, where it's a new medical center. They're also trying to understand how these things can help in the context of medical wellness programs. So they see that there is a potential need there. So we're trying to really evaluate primarily in the context of a research setting, but at least now we feel good that the clinicians are willing to embrace such tools in their practice. Um, so I guess this is kind of really the summary of what I really wanted to share, which is my preference is to work with data in the native format because I think there's a lot of value in terms of processing and harnessing that information. Obviously, it's very tedious, but I think there's a lot of value in terms of taking that raw data, whether it's an MRI scan or whether it's an EEG recording or a CT scan or even a PET scan. I think there's a lot of value in terms of relying on the raw data. Obviously, there are many tools such as FreeSurfer and other things which can allow you to get derived measures. Clearly, you can do something with them, but at least personally, we feel like there is exciting work that can be done in the context of leveraging this raw data and multimodal data. Um, because I'm a computer scientist, I really focus on validation because I know that, or at least I think it's very important to think about translation. And the only way to think about translation to really is to make sure that the models that we are building have meaningful value. And the only way to show that value is not by showing some accuracy or performance, but also really thinking about those uh, comprehensive steps in terms of bringing clinicians on board, showing the alignment of model with hopefully biomarker evidence or neuropathology evidence, and to really sort of really comprehensively uh, do all those things. And only then I think hopefully these tools can be translated. So if anyone's interested, I'm happy to talk more about the tool. With that, I just want to thank my sponsors and happy to take any questions.
All right, thank you, Vijay. Very interesting work. And we'll ask the audience if there's any questions. We got a hand up from Mike Fox.
Yeah, I'm blown away. Absolutely fantastic talk. Question for you: in these analyses where you threw all the data together, the MRI data, the clinical assessments, did it back out which source of data was most useful? In other
Yes.
words, if you didn't have all that data, was it
Yes.
relying mostly on the MRI, relying mostly on their age, the clinical assessments?
Yeah, it's a great question. So in one of the so there is a way for us to go back into each person's case and then and rank order the list of things that can be useful in terms of making that prediction. One of the things which I didn't get a chance to talk about is to that our model has the capability to make a prediction even if one data modality is missing. For example, we trained it on all the stuff that I just described, which is MRIs, EEGs, and all that. But if, let's say, you introduce a new case where EEG is not available or MRI is not available, it'll take whatever is available and still make a prediction with a confidence value. So in
Yep.
that, at least we feel like I think that's probably the primary reason why the Carl Health System is interested, because they're mainly looking at patients in a primary care setting or sort of more upstream neurology settings. And they feel like at least if the model can do an initial pass on the prediction with whatever information is available, then they can hopefully use that to sort of really decide on what kind of test can be recommended, or whether they have to, let's say, order an MRI or something like that. So I think there's a value in terms of creating these resilient systems which can take whatever is available and make a prediction. And to your point, yes, it is capable for us to rank order the important things at an individual level.
And if you do that for everybody, and maybe you haven't done it yet, but I'm just curious, is it more dependent on the MRI scan or more dependent on the clinical data, just to put it into two big buckets?
So, based on my knowledge and based on what I've seen, if I was to do a simple NC-MCID assessments, MRI doesn't turn out to be the most important modality. But if I have to look at certain aspects of, let's say, Alzheimer's versus traumatic brain injury, or Alzheimer's versus or some other mixed dementias, then MRI seem to play a bigger role in terms of making that kind of assessment. So, yeah. So,
I see. So it depends on, I guess, what the question is. It
yes.
relies on the MRI for some questions, it relies on the clinical data for others.
Yes.
Anyway, brilliant talk. I'll let other people.
Yeah. Thank you.
Go ahead, David. We can't hear you. I don't know. You're not muted, but we still can't hear you. It's in the chat, David. You wrote it down. The largest increase in diagnostic accuracy from adding the model of clinical adjustment is in CHI. And what I'm not sure which CHI is, but do you know what data or features underlay the improvement? So what's so good about the AI to improve upon neurologists? Um,
I
uh,
think if I, based on my what I've seen, I think for in the context of radiologists, for instance, when I gave them all the cases who have been clinically diagnosed with dementia, and when I asked them this question, okay, can you really list what are those contributing factors? Uh, they seem to do great on identifying the primary contributing factor, like finding, let's say, an atrophy pattern on the brain MRI. But oftentimes there is this not so much consensus on looking at other contributing factors. So again, when I'm grouping all their scores together, clearly there is some kind of a kappa value which is not that high. But clearly, I think by augmenting this kind of a standardized assessment, because the computer is only going to do in one way, because that's how we train the model. But because you have these experts who are probably thinking slightly differently, maybe there is not much consensus. So I think there's the way I think about this whole thing is to really think about how AI can help standardize some of these aspects, which hopefully can then be augmented to within the practice. So that's how I think I see the value. There is going to be variability because expert in Boston may think differently versus expert in India. For example, I'm trying to work with a hospital in India. One of the um, most frequent conditions there is B vitamin deficiency, which is not so much observed here, at least in the US, right? So for them, they're so much not biased, but they so much really want to ask that question as the first question because clearly a lot of people have that vitamin deficiency there, and that could be like hopefully a reversible cause of dementia. So I think depending on the practice, depending on the culture and location, there may be some differences in terms of how they assess. Uh, so hopefully, I think in an ideal world, I feel like AI could help standardize some of these assessments.
That's great. And the other question which I think David had, which I have too, is sort of when understanding the prediction of different underlying etiologic diagnoses to patients' dementia. It sounds like for some patients you had pathologic validation, but broadly speaking, what would be the gold standard for validating the model?
So you mean to say that we would want to validate on every condition or every patient?
I guess like to determine how good the model was, like the model plus neurologist versus neurologist alone was for classifying patients into different
Mhm.
diagnostic categories. So what's the gold standard for which
For
like
that,
how
yes, that's a good question.
for
Yeah,
that for the
yeah.
diagnostic
So for those
categories?
cases, yeah. So for those cases that we selected, we had a consensus diagnosis coming from reports like NAC or other things. So clearly there is a team that is, I think, evaluating the person as opposed to a single clinician. So that's, I think, what we are relying so far as a consensus diagnosis or a clinical gold standard, if you will.
I was particularly impressed by the fact that it could predict, hard pathology data, even which is even better than yeah, consensus diagnosis from NAC or whatever. I had one question. I guess Shabani has one too, but maybe I can just quickly ask. So as a cognitive neurologist, a very common question I get from my patients that I can't answer is what's going to happen to me in 5 years or in 1 year or in 2 years. So the rate of cognitive decline, sort of irrespective of the etiologic diagnosis. The etiologic diagnosis is important if you're going to prescribe someone lecanemab or enroll them in a clinical trial. Most patients don't really care whether they have Lewy bodies in their brain or amyloid plaques, but they want to know, what can I expect in the next few years?
Yeah.
So there's probably a lot of longitudinal data in these cohorts, and so can you take a cross-sectional or single time point or even historical data set and use the model to predict the rate of cognitive decline over the next 3 years, let's say?
Yeah.
Um,
I think it's a great question, and I definitely think it's a very important question as well. I don't think we have enough data as much as we have collected for this cross-sectional stuff, but yeah, it's definitely a great thing to do in the future. We haven't done that yet.
anecdotally, and I'm sure people agree, it's a big question we
Yeah.
face from our patients that we just can't answer. Shabani, go ahead.
Thank you, Andrew. That was actually the question beautifully asked. The question I had is how far in advance can you predict? And that's probably the key question. My other question to you was, I really liked your talk. My question on that value add, I'm curious, what is your plan to sort of prove that value add? So would you envision either implementing this where you had, for example, people randomized to the AI generated diagnosis versus the neurologist, and then actually showing that there's either a cost benefit, some benefit of some sort? And what
Yes.
are those benefits that you would look for?
It's a great question that's been in my mind for some time now. I think I can give a pretty decent answer on the clinical trial angle. Because the pilot study that we completed in Arizona, like I said, they are more interested in clinical trials. So what we observed was our model was able to predict biomarker positivity, uh, which was 33% higher. I haven't yet published the work, but the plan is to do that. So we were able to predict better biomarker positivity. When I say biomarker, I'm talking specifically about PET positivity, because they don't do PET scans often. The sponsor usually pays the money to get PET scans for these participants who are enrolled. So we took the data that is done in the neurology workup and we predicted who might turn out to be PET positive, both amyloid and tau. And we were about, on an average, 33% higher. So there is, I think, potential economic benefit there in terms of screening patients for these trials. In the context of clinical diagnosis, like we're just starting this study at Carl Health, the randomization was one of the topics that we discussed, but I think they are more aligned to think about Medicare wellness visits, where I think more primary care or geriatricians are involved in sort of really assessing these annual checkups. So they think that first of all, they don't have time. So they want to really get this first pass thing. But the economic benefit is absolutely the key to understand how this eventually becomes sort of a value proposition. Uh, but I think there are a few ways to do it. One, I think what you suggested is, I think, is a very great way to sort of really randomize and sort of really evaluate the cost and everything. We aren't there yet, but hopefully in the future we can do that. But from the clinical trial standpoint, at least there is a quantitative value that I think can be, hopefully a sponsor might like it as opposed to just the clinic.
More questions? I have lots if nobody else had one. Edinson, I think, has a question.
Yes. Hi, thank you for the talk. I have a question related to the use of diffusion MRI data. How do you envision to use in the future diffusion MRI data to kind of address some information about the connectivity in the brain due to Parkinson or Alzheimer's diseases?
I think it's a very important modality. Unfortunately, for any of the work we have done, we have not used diffusion MRI. Primarily because, again, I've been taught by the neurologist that that's not normally done in a clinical setting. Not everywhere, maybe in some places they do. So I think the whole motivation has been for us to really think about routinely collected clinical data or routinely collected neurology workup data. And in fact, that's the reason why I did not use PET scans as input to the model. In fact, we were also debating on whether to use CSF as an input, but we did in some questions. So we are trying to separate between what's practically available and what's kind of really a research question, which I think is a very interesting but a separate question. But in this context, we have not used diffusion MRI.
Okay, thanks.
Great. Other questions? Mike, do you have another one, or is it
I do, but I want to make sure other
Okay,
people
go ahead.
I don't want to see.
We have time.
I,
Go ahead.
I loved the heat map you showed. I think it was from your brain paper of the interpretable AI, where it actually gave you a voxel-wise map of which voxels it was using to make its decision making. Can that be individualized? In other words, you mentioned you can go to how it ranks.
Yes.
And on those single subject maps, I guess you could make a single subject heat map of what voxels it's looking at when it's making its differential diagnosis.
Yes.
And I'm just wondering if producing those single subject maps and showing those to a neuroradiologist or a neurologist, we all the time pull up these scans and argue about where the atrophy is or isn't.
Yeah.
I guess, is that something you've explored? And are those single subject heat maps actually useful for someone as an augmentation to interpreting the raw radiology data?
Yes, yeah, absolutely. I think the framework is capable of creating individualized maps. The example that I actually showed you was one single case from the Framingham Heart Study, which had postmortem data available.
Oh, so that heat map was one patient, not a population average.
No, yeah,
I
it's
see.
one single person. But we could obviously average it. But I think the case I was showing was on a single person.
Understood. And then you emphasize the importance of raw data going into the pipeline, and you brought the free surfer up multiple times. So everybody has their favorite way that they think they can process the data. Have you actually done a head-to-head of the raw data versus something like free surfer or some advanced analysis of that MR data?
We haven't. We thought about it. I think the just to be again, free surfer is fantastic. I think it does a lot of interesting things. First of all, it takes a lot of time. So
Well, yeah, I'm not saying everybody should do it. It was just more of a, is it an assumption that it won't add value, or is it proven that it won't add value? Because I get there's a lot of downsides. Agree.
um, I haven't done the study, so I can't comment on it. But I guess given that I'm coming from probably non neurology background, I never was a big fan of derived measures. Uh, I think clearly there's so much more information on the MRI. And if you are simplifying it to 100 scalar values, you're effectively synthesizing the information, right? So, but you're right. Maybe an interesting study to do would be to compare the free surfer derived measures and then,
So, sorry, not the free surfer derived measures, right? Not those scalars that are 100 lists of atrophy.
Mhm.
I'm more talking about the voxel-wise or vertice-wise map, right? So you're taking the raw MRI data, but you still have to warp it into a common atlas space so that your AI algorithm can compare each subject to each other. But how you warp the raw MRI data into atlas space, that was why free surfer got so popular. They said, hey, our standard way for warping into a single space isn't good enough. We're going to align each sulcus and gyrus. And so it's more of the normalization step, not the.
I see.
I agree 100% with the drive measure thing. It's more your platform could provide a really cool test of this debate of how do you normalize MRI data into atlas space so you can compare across subjects.
Yeah. So in that case, I think FreeSurfer is a very good tool. And there are a few other tools as well. So like McGill University, I think has created a lot of tools as well. There is MNI Space is something that we use. There is a Hammersmith Atlas. There is also Ron Kiliani Atlas. So there are many different atlases that you can leverage. So so the for practical reasons, for building that pipeline, we did not use FreeSurfer because we feel like other pipelines are slightly more computationally efficient. My understanding is that FreeSurfer is used not just to align or not just to register, but also somehow do the next step, which is to derive those measures. So for those practical reasons, we just relied on building our own pipeline. Right?
Thank you. Very cool.
Yeah.
Great. More questions? I have one more, if nobody else does, which is another selfish question about my own practice, about treating patients with anti-amyloid immunotherapy, which is new. There's a lot of things we face with, like, for example, predicting ARIA, but which is a side effect. But even more important, in my opinion, is predicting drug response. And another question we often get from patients who are on these new therapies is like, well, how do we know if the drug is working? Because the expectation is that a patient, even on the new medication, is going to decline longitudinally, just perhaps at a slower rate than if they wouldn't have.
Yeah.
So if you have hundreds of thousands of cases, again, would there be a way to put in as one variable, amyloid immunotherapy, duration of treatment, or something like that, and sort of try to quantify what its contribution is to a patient's status in a huge model to sort of derive at a patient level how much of their current status is affected by the fact that they're on this treatment. Does that make sense? Because we can't measure an improvement from the drug. It just doesn't. But can we quantify what they might have been like if they hadn't been on the treatment?
I see. It's like a what if condition. basically.
Yeah. Like to what degree does the presence of being on this drug improve likely to be mitigating the patient's cognitive status?
Yeah. It's a very interesting question, but seems like a bit of a risky question. I don't know. You can ask these what if questions today in the age of AI. I mean, AI is, I think, facing a lot of heat in terms of really thinking about there is some scrutiny going on, right? So I appreciate the question, but I don't know if I can.
Okay.
I am educated enough to comment on that.
I guess more broadly speaking, just say
Yeah.
not just about amyloid immunotherapy, but generally speaking, like what modifiable factors are affecting a
Yes.
patient's cognition?
Yes.
Whether it's being on a certain drug, whether it's their smoking status, so that you could tell a patient this is what you need to do
Yeah.
to make your memory better
So
or to prevent.
it's okay. So let's
Yeah.
talk about modifiable factor. That's I
Sure.
think a great way.
That's
So
more
for example,
broad. Yeah.
let's say again, I am deriving 100 features. Some of them are basically BMI values or some other things, or their diabetes status or smoking status. These are inputs to the model. So I can, in theory, effectively create a random perturbation on these values and then input that to the model and run 1,000 times. I can actually get different predictions every time. So effectively, what I'm trying to do is keeping everything else constant and maybe change one of these modifiable risk factors and then see how the predictions come out. And then perhaps then I think maybe think about those recommendations or suggestions on potentially changing a modifiable risk factor. So I think in theory, it's totally possible because effectively it's a microsecond time. The model is you just put the data and then it gives you the output. So, but yeah, I like the angle of modifiable risk factors, but I don't know if I can talk about immunotherapy.
Right. Okay. Well, I mean, if we did this
Yes.
change,
Yes.
you stop smoking, then we would expect that this change in your
Yeah.
trajectory or whatever.
I have a trainee who is interested in modifiable risk factors. He's thinking along those lines, actually.
Great. All right. Well, maybe you'll come back in another 5 to 10 years and you won't be talking to neurologists because we won't be needed anymore. You'll just be talking to some AI
We
bots.
need more of you. So I think there is one question on the
there's
chat.
one.
No.
Okay. All right. Sorry, Shibani. Are you there to ask it, Shibani, or did you had to go? Could the pipeline generate a hypothetical person based on a person's data and see if the trajectory differs from what they'd expect to be based on their demographic and whatnot data? Yeah.
So it kind of aligns to your question, which is about how do you not just think about prediction, but also trajectories as well. So yeah, I think these are possible. Uh, just to be honest, I think mainly coming from a completely different field, the biggest learning experience for me was to align with what clinicians speak. I think that took a while because what are the questions? I mean, I don't want to randomly create some fancy models. Like I think the first one, even though it's a small anecdotal here, evidence here. So the paper that was published in Brain was initially reviewed by I think Nature Medicine. I think after 4 rounds of revision, one of the reviewers made a comment saying that, oh, this is not clinically relevant. And it got rejected. So that was a learning experience. So I think I'm trying to understand what actually is the problem. Hopefully, build tools after that, as opposed to starting to build tools and going in that direction. So I'm still learning.
It's been terrific. This is obviously very helpful. They're going to be helpful tools to us and maybe even to primary care as well. Okay, thank you, Vijay. And I'm sure people can reach out with more, pepper you with more questions if they so desire. Thank you so much for joining us.
Thank you for having me. Appreciate it. Bye. Take care.
Thank you, Jay.
Bye.